braided genital or anal skin. So here's a little pretest. A 40-year-old man comes into the clinic with a headache, a rash on the scrotum, and a red right eye. What does he have? So the spirochete, slender, tightly coiled, again, 10 to 13 coils, only can infect human beings, and transmission generally is direct through sexual contact, also vertical from mother to child. But we're not going to talk about congenital syphilis here today. Once it enters through braided skin or mucous membranes, it will disseminate into the lymphatics and bloodstream. And the highest risk of transmission is actually during primary syphilis with the chancre. And transmission occurs somewhere between 30 to 50%, at least 30% of the time, with one encounter with the primary chancre. And again, sexual contact is the primary mode. It's highly infectious disease with a small number of organisms causing disease. And then there's congenital syphilis, and other modes of transmission nowadays are quite rare. So a little illustration of the natural history of syphilis. People get exposed through sexual contact, and anywhere from 4 to 5 weeks later, typically, they would develop a primary chancre, which would last anywhere 2 to 8 weeks, typically a little shorter than that. And then it would clear on its own without any kind of treatment. And then days or weeks later, people would develop secondary syphilis, which is a skin rash, mucous membrane involvement, and condyloma lata. And then that would clear even without treatment. And then people are in a stage called early latent syphilis. So they have a positive blood test for syphilis, but no physical findings. And if that is less than a year in duration, that's what we call early latent syphilis. And the reason we worry about early latent syphilis is about 25% of people with early latent syphilis will have recurrent secondary syphilis, and in which point they become infectious again. If they're strictly latent and they have no physical findings, they're not infectious any longer. And then, as you can see, about 3/4 of the population with early latent syphilis progresses to late latent syphilis, and then they clear their disease without any further complication. And maybe 25%, 20 or 30 years down the road, would go on to develop neurosyphilis or cardiac disease. But we don't see that anymore, typically. Enough people probably take enough antibiotics in their life that they don't get the late sequelae of syphilis. All right, so primary syphilis, the chancre is the typical lesion for primary syphilis. And the earliest it would show up after infection would be about 10 days, maybe as late as 3 months, but typically 3, 4, 5 weeks it would show up. Starts as a small red papular nodule that then within a few days would open up into an open ulcer. It's indurated, it's typically painless, and it's very infectious. And then everybody who has a chancre will develop regional lymphadenopathy within a week or so. And then the chancre lasts for a few weeks, and then it would clear spontaneously. So the differential diagnosis that we would worry about with primary chancre would be confusing it with herpes, some sort of bacterial infection. And these last three here on your left, chancroid, lymphogranuloma, venereum, and donovanosis, are very rare conditions nowadays, and for the most part we can forget about them. Other situations that can cause genital ulcer disease would be carcinoma, Behçet syndrome, aphthous ulcers, fixed drug eruptions. But all those are fairly easy to sort out. So how do we diagnose this? We want to know how long it's been around. We ask patients, is it painful? Did it start with a blister or vesicle, which would be much more typical of herpes? When their last sexual contact was, are they putting on anything on it? Have they had a history of ulcers in the past, as they might with recurrent herpes? Have they been anywhere lately? In physical examination, we look to see how many ulcers they had and where they were located, what the size and the shape was. Typically, chancres tend to be fairly round with kind of rolled, raised edges. They typically tend to be clean on the base, not purulent. They typically are not tender, and they're indurated, which is this sense. This is what a chancre will feel like, what the tip of one's nose feels like. And then it has an accompanying lymph node. So these are how we would work up a genital ulcer. Any good STD examination would also include looking in the oral cavity and looking at the perianal region. So Gundo and Silver and I have spent a lot of time this week setting up dark field microscopes at both Epicentro and Barton. So we want to actually look for treponema pallidum from fluid from a lesion. We can do stat RPRs and TPPAs, and at least at City Clinic in the US we can do a herpes PCR and perhaps an HSV2 serology. And then we want to see people back in a week. So now we're into the racy photos here. So that is a primary chancre in a very typical location, what's called the coronal sulcus. And if everybody does this, that's what these things feel like. And this is what treponema pallidum looks like under the dark field microscope. And there are maybe 8, 10, 12 coils. And it's about the length of, or maybe a little longer than the diameter of a red blood cell. And they're doing this underneath the microscope, and they're doing this, and they're moving around. And we need to see all those motions in order to make a diagnosis. There's another chancre. There's actually 4 lesions here. These ulcers were not indurated. They were completely flat. He's HIV positive, had very low T cells, and he could not mount much of an immune response. Therefore, he couldn't indurate. So there were no CD4s.
So in this case, looks like herpes infection. So
Well,
we have multiple sores, multiple ulcers,
Well,
which is the non-typical.
it was not typical, really. It kind of surprised me a little bit, but these were dark field positive. So that was the advantage of having a dark field microscope. With herpes infection, with primary HSV, first-time HSV, you would see very widespread lesions. With recurrent herpes, you would tend to see very grouped lesions. And this was sort of in between. His last contact was about a month before. These were 3 days old. And his last contact was about a month before that. What was interesting here is his RPR was non-reactive. So the only way we could diagnose him was by a dark field microscope and actually seeing treponema pallidum, because he had what we call seronegative primary syphilis, or he had not had time yet for his RPR to turn positive, to develop antibodies to syphilis. So that can be unusual and kind of tricky to diagnose. And he also, this photograph's probably, I don't know, 12, 15 years old. And this guy still comes around every once in a while. He wants to borrow money from me. So I give him $15 or $20 maybe twice a year when I see him. And I figure those were royalties for his photograph being shown all over the world. Here is a primary chancre, dark field positive lesion in a man who'd had syphilis before. So in people who've had syphilis, prior cases of syphilis, oftentimes their primary, if they get syphilis again, their primary chancres can be fairly atypical looking, like this one was. Sort of small, not that indurated, can often be overlooked. But again, that was a dark field positive ulcer. These were all chancres. So multiple chancres can occur, particularly in HIV positive individuals. So we weren't, it's likely he's HIV positive. He didn't stick around to take a test. We treated him with penicillin, and I'm sure he got better. We haven't seen him since, but it's very likely he's HIV infected. Again, multiple chancres. Perianal lesions. When we look at the anal area, anything that's at 6 o'clock or 12 o'clock is very likely to be an anal fissure. Anything that's not at 6 o'clock or 12 o'clock, we have to consider syphilis to be high up in the differential diagnosis. And we can do dark field microscopy from a lesion like that. Can't see that very well, but back on this tonsil is primary chancre. And he had a huge swollen anterior cervical lymph node. But again, we cannot do dark field lesion from dark field microscopy from a lesion inside the oral cavity, because there's another treponeme that lives in the oral cavity called Treponema denticola, and they look quite similar under the dark field microscope. But his blood test was positive. Now we could do a dark field microscope from that lesion. And here's the famous finger that, so this is a primary chancre on the left pinky, fifth finger in a right-handed man. So how it got there, anybody's guess. But we were able to get some fluid out of that and do a dark field. So secondary syphilis. Sometimes there'll be patchy alopecia, skin rash. condyloma lata, mucus patches, and folks with secondary syphilis often feel they're ill. Maybe they have low-grade fever, sweating at night, fatigue, headache. So it's going to occur after primary syphilis typically, or maybe the primary chancre is still in existence when people develop secondary syphilis, so there may be overlap. Again, more typical in folks who are HIV positive to have that overlap. And it can take months for secondary syphilis to develop after exposure. And it's going to last a few weeks, and then it also would clear on its own. And secondary syphilis will often show up with a rash on the palms and the soles, although not always. So the differential diagnosis of secondary syphilis, we oftentimes will see folks who are acutely infected with HIV can have a generalized rash that can often be mistaken for secondary syphilis. Pityriasis rosea, drug eruption, lichen planus, guttate psoriasis, sarcoid. And for the palmar rash, could be erythema multiforme or Rocky Mountain spotted fever, which is very uncommon in the United States. So this is a very typical rash in secondary syphilis. Bilateral symmetry, same on both sides. And all of these lesions are more or less the same size, same shape. Typically not pruritic. That is psoriasis, or what's called guttate psoriasis.
It looks very similar.
Yeah, it does. So sometimes it's hard to sort out. The RPR will be non-reactive in this case, and highly reactive in this case. So the RPR serology is the way to differentiate these.